I would say that while we're getting the slides up, I'll be giving you an introduction to the virus and an introduction to the pathogenesis of how it works in the human body. I'll talk a little bit about the sexual preferences that the virus has, whether it attacks men and women preferentially, the age preference of the virus. There we go. If you could just make that full screen. Yep, the outline of the talk is what I'm talking about at the present time. There you go. And just Dr. Patel, hit the slide presentation button up above. There you go. Thank you. That should do it. I hope everyone can see that. So I'll be talking about the age preference, which you've been hearing nightly on the news and in the media. People with potentially dangerous morbid conditions that predispose them to having a very bad time and, in fact, death from the infection. And then we'll talk about medications and the progression of our interesting knowledge about how to treat this condition, even though there is no cure at this time. And then I'll talk about very controversial aspects of mitigating the infection, the question of lockdowns, which, as you know, is on the news every hour at the present time, whether you should lock your state down or we should lock the country down, and the events called super spreader events, where one individual can infect as many as 500 people. Lastly, I would like to talk about vaccines. But before I talk about vaccines, as of just off the wire this morning, I want to talk about the fact that this virus may become endemic in our society, meaning that it is liable to surface every year, even with the vaccines. It will become like influenza, where every fall, or perhaps every spring, we don't know. We don't know about the cyclicity of this virus. That's when it appears and when it disappears. We may be offering a vaccine every year to affected individuals. And I'll explain why that is likely to be the case. Can I have the next slide? So this infection is an extremely interesting thing. The virus is related to Middle Eastern respiratory syndrome and SARS-1. The origin of the virus is said to be from an animal in China. The pangolin was one of them, and the other was a bat. So this virus and these viruses, which originate in animals, do jump species periodically. Most of the time when they jump species, the virus burns itself out and nothing happens. But in the case of this particular virus, the COVID-19, it jumped into an individual in China, and the rest is history. As we say, it spread. If you look here at phase 1, which is 1 to 6 days, the patient develops pneumonia. The symptoms of this virus include fever, loss of taste and smell, a chronic dry cough, shortness of breath. Now, you can also have a variant of the virus, which includes nausea and vomiting and diarrhea. The symptomatic infection occurs in 50 to 70% of the people who get it, and that's phase 1. Phase 2 is what we call the intercritical phase. The intercritical phase is recovery. This is where you either recover or you go on to respiratory decompensation. And unfortunately, people who are short of breath with this virus and coughing oftentimes do not seek medical care. And that is what exactly happened in the midst of the pandemic in the spring in our area, New Jersey. People would not come to the hospital for fear of getting the virus when in fact they already had it. So respiratory decompensation is the bad part of this. Respiratory recovery is where you can recover from the virus within a number of days. Now, we will talk about the long-term effects of both of these. However, the respiratory decompensation is the bad one, and that's where something called pulse oxygenation, or the level of oxygen in the blood, goes below 90%. It can go down to 80%, and you will feel short of breath. It'll go down to 60 or 70%, and you'll likely lose consciousness because of lack of oxygen. And that's precisely what happens. So this phase 2 is between 7 and 10 days. Now, phase 3 is the horrible stage, and that's where you have acute respiratory distress syndrome, or ARDS, or shock, and you can have them both together. And phase 3 is where we get you in the hospital and we aggressively treat you and may put you on a ventilator. The ventilator is a machine that helps you breathe with a tube that goes down the trachea. And about 10% of the patients that initially present over on the left side of your screen, I don't know if I can use the pointer. I think I can right there. Can you see that pointer? That is the first phase. And if you can get past the second phase and recover, you don't progress to the third phase. Now, here's the thing. I say on television, as I did yesterday on CBS News, that we never know who's going to succumb to this infection. It can be a 20-year-old, and as you saw in the news this morning, an 18-year-old in South Carolina died of this infection, a perfectly healthy young man. And the thing was that we have no idea what the immunogenetic predisposition to death is, or whether or not your immune system is capable of confronting this infection. May I have the next slide? So what happens with this virus? This virus replicates. That means it multiplies in the lung. And you see on your screen that there's something called the ACE2. That's an angiotensin converting enzyme 2 receptor. That receptor, and I know the lay people really, it's not important to remember anything except ACE2. And ACE2 is the receptor that is in both the lung, it's in the heart, it's in your blood vessel surface. And 78% of the people that get infected have virus in their blood at 7 days. Then we go over to dissemination. Dissemination is where the actual virus goes into the cells and it replicates. Because remember, the virus is not alive. So it goes into the cells and it replicates and creates multiple copies, millions of copies. And those copies go on to infect other cells and such. We have multi-organ infection at 14 days. 25% of the people infected get what's called a viremia, which is a virus in the blood. Now, on the bottom of the slide here, yes, that's great. And by the way, I want to credit Dr. Richard Buchala from Yale University, who was able to lend me these slides. Rick and I are both associate editors of the 6th edition of our textbook coming out in July of next year. And Rick, I knew Rick had been developing these slides. He's a great immunologist. We both were at Rockefeller University together for many years. And so he was kind enough to give me these slides to show you all this morning. The immune response is critical, and that's on the bottom of this slide. And you see that there's a response of something called cytokines, which are chemicals which allow cells to communicate within the immune system. Interferon, which is a natural antiviral substance that is secreted by cells. The interferon blockade has been one form of potential therapy for this. Neutrophils, which are white cells, monocytes, which are also white cells, something called DAMPs, which are damage-associated molecular patterns, are established within the immune system. And there's a response from all these cells, including the cells of the blood vessel walls. The blood vessel walls, the endothelial cells, become infected and they are damaged. And that's very important for what I'm about to say with regard to blood clotting. Then you go into the second phase, phase 2, and you see how the B cells and T cells, two immune populations within the body, are affected, and something called cytokines are secreted. Cytokines are these chemicals that are communication molecules between cells. They are originally set up by that group of cells you see there between phase 2 and 3 called macrophages, which is where the virus presents itself to the immune system. So the macrophage recognizes the virus and says, this is a foreign substance and we have to mount a response. So there's an innate response. That's an immediate response, which all of us have to any kind of infection or foreign material brought into our body. And then we have 3 days later an adaptive response where antibodies are made and specific cells attack the cells that have this virus. Now, the virus is the criminal. So tissue dissemination of the virus is not a good thing. We saw the same thing with HIV back in the 70s and 80s, where the virus hijacks the cell. And in that case, it was the immune system. In this case, with SARS or COVID-19, almost all of the cells of the body get hijacked and become little viral factories for the promulgation of the virus. Now, on the last part of the third bar here, you'll see an arrow going up that says endothelium D-dimer thrombosis. What does that mean? That means that the wall of the blood vessel, which has been infected, now becomes active and induces blood clotting. So in patients that are really, really sick that we put into hospital in phase 3 that are near death, we anticoagulate them. We give them injection. We give them blood thinners like low-dose heparin. And recently, I saw a report out of the Lancet of England, which said that 47% of patients that there was a death rate that was decreased by 47% of patients who took baby aspirin every day. People were infected, took baby aspirin. And why is that? That makes a lot of sense. That's because the aspirin, which we give to people for strokes and potentially heart attacks, the aspirin really acetylates the platelets, and very important part of the clotting mechanism, and it prevents the clots from forming in the heart, for example, in the brain, in the lung. With regard to COVID-19, the big problem is in the lung, where little microclots form and block the circulation to the little parts of the lung that exchange oxygen with the blood, and that's called the alveoli. These alveoli can be completely thrombosed. And so if we give blood thinners, we prevent that from happening. And you see that the liver is involved, the heart can be involved, and you can have heart disease, and that's one of the great long-term effects, or as we call it in the business, the long haulers, people who recover from COVID-19, but then develop congestive heart failure and other problems. And then also the kidney is involved. Now, down at the bottom of the slide, these two cells, I think maybe I can point to them here. These two cells are lymphocytes which begin to die. And these lymphocytes are due to the fact that they're activated and they go through what's called programmed cell death. And programmed cell death has a name. The name is apoptosis. It's not important to remember that. It's just important to say that the white count completely goes down in the patient, and we know that that's a sign of trouble. Can I have the next slide, Dr. Patel? Now, here in this slide, you see something very interesting, the clinical consequences of the COVID-19 hyperinflammation. Now, hyperinflammation means that your body is superbly or robustly inflamed during this acute crisis. After this virus enters, your body becomes completely hyperinflamed, and that causes the top, acute respiratory distress syndrome, right there, hypotension, low blood pressure and shock, coagulopathy, which I just explained, which means your blood clots prematurely in bad places, myocardial depression, which means your ability of your heart to function as a good muscle, it decreases. And so you run into the possibility of having congestive heart failure. Now, this is not a problem for an 18-year-old or even a 30-year-old, but it is a problem for a 70 or 80-year-old, where myocardial depression can result in death. Acute kidney injury, and we've seen a few of those, is kidney failure, complete kidney failure. And then these patients oftentimes have to undergo dialysis. And then lastly, complete immunosuppression, because as I mentioned, the lymphocytes apoptose, or because of programmed cell death, they die. And these are all the clinical consequences of COVID-19 hyperinflammation. And if you press the next slide button, you'll see at the bottom of this slide, we pop up with what's called cytokine expression syndromes. Now, for the layperson, this may sound like something very, very complicated, but it really is not. Remember what I said, that cytokines are communication molecules. And if you look at the immune system as a police department, you know that the police cars have to communicate with headquarters, and police cars and police officers communicate with each other by little walkie-talkies. That's what the cytokines are. They're communication molecules. It tells a T cell who's in the brain about a B cell that's in the kidney, and they communicate with each other. So the adaptive immune response knows exactly what is going on in your body at any particular time. And you see here that COVID-19 is in this bubble graph. And you see that over here, and I don't know if my arrow can show it, but that little, I guess it's a gray circle, it says SJIA MAS, MAS. MAS is one of my favorite syndromes. That's macrophage activation syndrome. I have treated many patients with autoimmune disease that develop this death-dealing macrophage activation. It's better known as cytokine storm. Cytokine storm, you've read about in the newspaper, etc. It is a common cause of death with this COVID-19 infection. The other thing that it has a big long name, which I love to pronounce because the medical students and residents love it, hemophagocytic lymphohistiocytosis, HLH for short. And I never go and say hemophagocytic lymphohistiocytosis. I always go macrophage activation. But regardless of what we call it, it is deadly. And this virus is one of the causes of macrophage activation syndrome. And what it basically is that the immune system is completely overcome. And it says, wow, we not only have an infection, but the entire body's infected. So we have to do something. And these cytokines are sent out all over the body from a variety of organs and to the variety of organs. And what you have is hyperinflammation, and you have a disaster waiting to happen. And that's how people die with this syndrome. Next slide. And here you see COVID-19 hyperinflammation again at the top. And COVID-19 hyperinflammation results in elevation of a number of what we call cytokines, these communication molecules. Ferritin is actually not a cytokine, but it also goes up, and it comes from the macrophages. The macrophages are those cells that get the virus information first. The macrophage goes absolutely crazy and starts to produce tons of ferritin. And actually, one of the ways we can tell the difference between influenza and COVID-19 is to look at the ferritin level. The ferritin level is above, say, 1,000, and this is data from Wuhan, actually, early on in intensive care medicine in 2020, Wuhan, they showed ferritin levels of 20 and 30,000. And in cytokine storm, the ferritin levels can get extremely high, upwards of 30,000. You see then below that is IL-6, and that's very important to our drug therapy. IL-6 is interleukin-6, and that's associated with extreme inflammation, not only in COVID, but in rheumatoid arthritis and in lupus and other diseases of the immune system. IL-2, tumor necrosis factor, IL-1, I won't bore you with the rest of these. Suffice it to say that all of these cytokines or molecules that are increased as a result of the COVID infection go through the roof. It's an extraordinary thing that I personally have never seen in the immune system in all the years I've been an immunologist. Next slide. Now, acute respiratory distress syndrome, oh yes, I should say here at the bottom of this slide, thank you very much. COVID-19 is not macrophage activation syndrome. It's a viral pneumonia which leads to acute respiratory distress syndrome. And the ferritin elevation is elevated, but it's not as bad as macrophage activation, which ferritin levels are 20,000, and in COVID-19, they're about 300 or 400. And lastly, cytokine expression is generally lower and distinct, but it is up there and it is elevated. Next slide. And with the next slide, you see diffuse inflammatory injury of what we call the alveoli, or those little sacs in your lung, which exchanges oxygen with the blood. There's diffuse inflammatory alveolar injury. This is where the trouble happens. And this may be long-term. So someone mentioned the long-term effects. Well, if you recover from COVID, this alveolar injury can result in lung scarring or even fibrosis. And you see next to it a beautiful rendition, a computerized, I guess it is an MRI, but with special, you see the vasculature, the vessels of the lung, how fine they eventually become in the outer reaches of the bronchiole. So the alveoli consist of microcapillaries. Remember, these microcapillaries clot. So when the microcapillary has microclots, and that's why we thin your blood, that results in big problems with regard to oxygen exchange. And that's precisely what happens in COVID in many people. The initiating insult is the virus, and then the latent period, which is sometimes prolonged. And by that, I have to explain that. There's a 30 to 40% mortality. It means 30 to 40% of people who get this die. And that's ARDS, ARDS, acute respiratory distress syndrome. But going forward, if you recover from this, I have seen a number of patients who have developed what we call fibrosis of the lung and remain having breathing problems even 2 or 3 months after the COVID infection. And a lot of that is most likely due to the fact that early on when we treated this disease, we had no idea about the clotting problems that occurred. So we did not anticoagulate patients, which we now do routinely. You come into the hospital with COVID-19, we inject you with low-dose heparin, which is protective for you to prevent these microclots from forming. Now, if you could just continue the second part of this slide, is a word about COVID-19 and acute respiratory distress syndrome. This pneumonia, as I mentioned, is often characterized by severe hypoxemia, which means low oxygen level, but good respiratory mechanics, which means your lung keeps functioning, but the oxygen level is low. And that's what makes us believe that the acute lung injury is both inflammation as well as microclotting. The inflammation we can treat. The clotting is very difficult to treat, and that's why it's important early on to give the blood thinners to the patient when he or she enters the emergency room. But the damage to the lung can be long-lasting. The acute inflammation we've learned to treat with steroids, which I'm going to show you in a minute. And what's the steroid? The most potent steroid we have is dexamethasone. This is what Trump got. Trump got remdesivir. He got dexamethasone, which is like a nuclear bomb of corticosteroids, which immediately ceases the hyper-functioning, the hyperinflammation within the lung and other organs for that matter. Next slide. We target interventions, and I'm sure this slide that is going to be next will bore you to death, but these are the interventions for the hyperinflammation. Curiously, on this slide, you will not see remdesivir, which is the drug that the FDA has recently approved for the treatment of COVID-19. 5 days of remdesivir for every patient that comes in who is serologically positive or polymerase chain reaction positive for this virus. Everyone that comes in gets remdesivir for 5 days. But here are some of the other drugs. You'll see at the top, glucocorticoids. And the biology of how they work is not really of interest to most people, although this slide would be available. We block IL-1 with a drug called anakinra, or sarilumab and tocilizumab, or IL-6 blockers. We use those in patients with severe acute respiratory distress syndrome. So you get cytokine blockers that we already have approved by the FDA for use in other diseases such as macrophage activation syndrome, rheumatoid arthritis, associated lung inflammation, etc. We use all of those, everything at our fingertips. And believe me, in the beginning of these infections, we were caught with big problems. You may remember our president was taking hydroxychloroquine, and people still swear by hydroxychloroquine, and it may have some usefulness outside of the hospital as a prophylactic, but certainly not in the hospital. We saw no positive effect of using hydroxychloroquine or Plaquenil in patients who were presenting with very serious lung disease like I just showed you. It had no effect whatsoever. Neither did Zithromax. And in fact, they could have been harmful because we saw changes in the electrocardiogram, and some of those changes could predispose an individual to what we call tachyarrhythmias or irregular heartbeats, which are deadly. So the maturation of our knowledge over the past 6 months has been extraordinary and exponential. We have learned to deal with this disease, and we have learned to save a lot of lives. We do not ventilate as many patients as we used to. We don't put people on respirators as we used to. We use high flow oxygen, and we use masks. And when we can get by with raising their oxygenation using those means, we don't have to put a tube down their trachea and put them on a ventilator. And that has been the case, which decreases the mortality or the death rate. It was often said that if you were on a ventilator, your chances of surviving were about 50%. So this was not a good thing. We've learned to prone patients, roll them on their stomachs to allow better ventilation of their lungs. Clearly, respiratory failure was what is killing people with this condition. So this is very, very important to take this approach, the approach of almost experimental approach. Everything, and I can mention all the drugs because I had firsthand experience. We thought of ivermectin, which is an anti-parasitic, which some people in China had said worked. It did not. We used hydroxychloroquine and zithromax early on, which did not do anything. We were looking at other cytokine inhibitors, things that would neutralize interferon, which has yet to be shown to work. But I am told by the investigators that the drug, as I have it here, it's called Palumab. It's a monoclonal antibody. It's on the list here. If I can show you that, it's over here. And they came up with the idea, some of the research people that I've talked to at Harvard came up with the idea of using an interferon inhibitor spray that they could they spray into the patient's lungs via an aerosol and use that as a therapy. It's very effective to use an aerosolized medication with regard to lung pathology. So that was a good one. But the basis for our therapy right now are three things: remdesivir, dexamethasone, and low-dose heparin. And if you're smart enough to use low-dose aspirin, if you develop symptoms of COVID, that's a good thing. Low-dose aspirin is 81 milligram aspirin. You can buy it in the pharmacy, in your gas station. You can buy it in your supermarket. And it's extremely effective, decreasing the death rate, at least in the United Kingdom, by 47%. Next slide. So here you see the tocilizumab, which is anti-IL-6. We use this only on the worst of the worst cases, and we've given it to patients who have been quite ill. There have been report data from China and Italy, which focused on this, and the Yale New Haven healthcare system has been using it as a recommendation, and the people who are involved in the research in Rick's lab have noted that we give tocilizumab early on in patients who are developing acute respiratory distress syndrome. Next slide. And I'm not going to bore you with this slide. This is the tocilizumab and its usefulness. Next, you'll see the bottom part of the slide if you advance it by one. And you'll see that, there you go, that we use a number of markers to denote who is going to be very, very sick. One of those markers is ferritin, but there are three here. Keep pushing the button because a little bar graph will come up next to, there we go. And that shows you the days following tocilizumab administration in both non-severe and severe disease. The severe disease is the blue, and the red bar is the non-severe. And you can see that by day 14, that the percentage of improved patients with tocilizumab therapy is significant. And these are patients who are dreadfully ill with acute respiratory distress syndrome. The markers that I use are C-reactive protein, which you see on the left side of your screen here, IL-6, which is the interleukin that we're inhibiting with tocilizumab, and on the bottom here is soluble IL-2 receptor, which we also look at, but it's more of an experimental. This third one is more of an experimental analog that we look for in blood. Next slide. So what about glucocorticoids? This means, what about cortisone or dexamethasone? In the 1980s, this was protective in mice of influenza and influenza lung disease in particular. And we had considered treating patients with bad lung disease with methylprednisolone, which is a form of prednisone or cortisone, 40 milligrams every 8 hours. And that had a tremendous effect on inflammation, this hyperinflammation syndrome. It turned it down. And what had happened was, this was a fantastic observation, which was very, very promising. Next, press the next button and you'll see it develop on the screen. And you see here, the original paper that came out just recently was dexamethasone in hospitalized patients with COVID-19. This is not something you take at home. This is something that you we give you when you come to the hospital and you're critically ill. And the preliminary report showed that with supplemental oxygen, 11% of people improved survival. With mechanical ventilation, 29% of patients improved survival with the dexamethasone. And as far as the oxygen requirement, there was no oxygen requirement which caused harm. so we could give lots and lots of oxygen and the dexamethasone and make sure that our patients were breathing well. And the next part of this slide, if you press the button again, you'll see the graphs. The graphs will come up, and you'll see the difference between dexamethasone and no dexamethasone with regard to mortality, which is on the ordinate of these graphs. The mortality was significantly decreased in that number is that letter B slide, or that letter B graph over here, where the dexamethasone actually helped the patients considerably. It really was a remarkable observation, and we now use it routinely. And as you heard, President Trump did receive a bolus or many boluses of dexamethasone, which allowed him to get up on the White House balcony and rip off his mask and feel like he was Superman. Next slide. So what do we know about immunosuppressants? Well, we're doing all sorts of things. There have been 4 research clinical trials, 29 cohort studies, and 12 case series showing that there's no benefit to the use of hydroxychloroquine. With regard to anakinra, which is the anti-interleukin-1 cytokine inhibitor, not the IL-6, that's tocilizumab, but anakinra, we didn't see a major effect there either, and Yale backs this up. And some of these data are from the American College of Rheumatology, where I'm a master, and Rick and I are both senior members of the American College of Rheumatology. And rheumatology, by the way, figures largely in the expression of this disease because of its many, many immunologic parameters. Next slide. And I think this may be next to the last slide. Yes. This slide shows you, and press the button for the underside of the slide. This is a risk, okay? The New York University cohort showed that there were 103 inflammatory arthritis patients who were on glucocorticoids and had been receiving cytokine biologics, anti-cytokine biologics, and they did not get sick when they got COVID, which shows you, and this is very interesting, that if you are on an immunosuppressant now, and patients say to me, oh, no, I'm on drugs, I can't get COVID, I can't get COVID. Well, you want to avoid getting COVID, number one. Number two, if you're on immunosuppressants, you'll probably do better than the general population because you're already somewhat immunosuppressed, so that when the virus produces a hyperinflammatory response, a hyperimmune response, you're going to be somewhat protected. And that's what this slide shows, that the comorbidities and disease-modifying drugs on clinical outcomes were positive, were good. Next slide. This is the last slide, and I'm going to be talking about children in a second and young people. But this slide refers to the pediatric multisystem inflammatory syndrome. You may remember a few months ago, young children were getting COVID, and very rarely they got something representative of a disease which we have been calling for years Kawasaki disease, named after Dr. Kawasaki in Japan. And this syndrome was very, very bad for children. However, all children recovered from it, and the way we treated it was with aspirin, believe it or not, and we gave them intravenous immunoglobulin, or IVIG. That's pooled synthetic antibody, which we can give you by vein. And by the way, we've tried that on adult COVID patients as well with limited success. Now, this multisystemic or multisystem inflammatory syndrome in children is not Kawasaki's. It's deadlier, and it results in the death rarely of children. Can you just press the button and the right side of the slide will come up? And you see there that the pediatric multisystem inflammatory syndrome is temporally associated with SARS-CoV-2, mimicking Kawasaki, exactly what I just said. 16 cases were detected 6 weeks after the outbreak in Paris, France, and it is distinguished from Kawasaki. It's an older age group. Kawasaki, when I see it, occurs in 5-year-olds or below. Multi-system inflammatory syndrome occurs in anyone up to the age of 20, and it's pretty nasty. The platelets drop. There's a higher rate of heart inflammation. There's resistance to intravenous immunoglobulin, which we use routinely to treat Kawasaki's, which all got better, and much higher and greater inflammation with regard to those cytokines I mentioned, IL-6 and IL-1. and severe diseases associated with, remember, that ferritin level that I mentioned. So this is a disaster, immunologic disaster. And we saw this just pop up. And in New Jersey, we have seen upwards of 150 cases of what I call MIS, or multisystem inflammatory syndrome. I am not a pediatrician, but I'm very interested in this particular aspect of COVID-19. This is my last slide. Now, I'd like to talk a little bit about vaccines. And I'd like to talk about sex predilection for a minute. I showed that on my introductory slide. This disease is very, very common to both men and women. It occurs primarily in a deadly form in people who are over 70 years of age. If you have comorbidities meaning heart disease, chronic obstructive pulmonary disease, or you have diabetes or severe hypertension, and you're elderly, you will not do well with COVID-19. Now, the survival rate for that age group that's over 70 is 94.6%. The survival rate for people between the ages of who are newborns to the age of 20 is 99.98%. And that survival rate gradually goes down. So you see the death rate is not very high, even when you get into the elder populations. Those without comorbidities. This is a very controversial aspect of COVID-19, because what the political people are saying, both Democrat and Republican, is that the death rate is very, very low in young people. The morbidities, that is the side effects of the infection, even if you recover, are possibly long-term with regard to your lung and with regard to your heart, two major organs. There are reported cases of neurological deficits as you go forward after recovering from this disease, memory loss, brain fog, etc. There's also that small group of people who get kidney compromise and wind up with renal failure. So that's number one. That's the age groups. And that's very important because there's a swirling controversy right out there now, which is on the news every single day, about survival and the need to lock down. Now, I don't think the society should be locked down, but I do think everyone, and I've said this about 1,000 times, has to wear a mask everywhere, except in your home with your loved ones and relatives that you know are not infected. But you must wear a mask outside, and you must wear a mask if you go to the supermarket or the drugstore or the gas station, and you should keep your social distancing at least 6 to 12 feet when possible. And this is because the virus is transmitted vis-a-vis droplets, and it is transmitted now, I'm told by the World Health Organization, by aerosolization. What's an aerosol? An aerosol is a foggy spray which happens to occur, for example, when you use underarm deodorant. If you use those spray deodorants, you know the cloud that arises, that's an aerosol. And that's what happens when someone sneezes. If they're wearing a mask and they sneeze, it's fine. Same thing happens with coughing, although coughing is more droplet than aerosolization. So it's very important to have people wear masks and socially distance themselves. Now, with regard to sex preference, men tend to do worse than women. We simply don't know why. We suspect it's because a woman's immune system is very robust. Why is it robust? It's robust because her immune system is finely tuned. Hence, the occurrence of autoimmune disease in women is very common versus in a man, it's very unusual. The other thing is that men tend to have lower antibody levels and lower T-cell responses. That's a lymphocyte that responds to the virus. So a man is at more risk of having a bad outcome than is a female. And lastly, there's that unknown factor, which involves virtually everyone. We simply do not know, as I said yesterday, that who is going to succumb to the virus. And so it's important for everybody to mitigate. I would agree with the politicians that a lockdown may not be the best option because, again, the survival rate is so high so that the vulnerable populations, such as those people in nursing homes, the elderly people with comorbidities, etc., should stay out of circulation and continue to wear a mask and even rubber gloves when you go to the supermarket if you're an older individual. Now, my last point, and I will end, and I don't know if I'm over time, but my last point is going to be about vaccines. We have 4 companies who are vaccines phase 3 in completion. One of them, Pfizer, is going to be ready, I believe, next week, if not the week after, certainly by the end of November. I predicted on one of the news programs that our vaccine from AstraZeneca and the Oxford trial would be ready by Christmas. Despite that, each company has its own advisory committee that has to go over the data before the data are released to the Food and Drug Administration. The Food and Drug Administration has an Uber committee that oversees and looks at the data, and then they give it to the FDA Advisory Committee, which consists of epidemiologists, virologists, and other physician specialists. I sat on 2 of those committees for many years, and we're sequestered in a conference room, and sometimes it takes a day or 2 days to go over all the data. So you see, there are 3 separate approval committees. They have to approve this phase 3 completion and look at all the data. Undoubtedly, there are side effects from these vaccines, and you've heard about them. You've heard about the transverse myelitis that occurred in one patient, expected for sure. With 50,000 people in any one clinical trial, one is going to get deaths from both the placebo, that's the sugar pill group, versus the vaccine group. You're going to see deaths, you're going to see heart attacks, you're going to see strokes, you're going to see all of these things, particularly if they test a population that goes from age 20 to 90, which is what the goal is. Now, they're including children more recently because the vaccine for children is going to be a different dose, and that has to be looked at as well, placebo and patients getting vaccine. So the vaccine clinical trials are very encouraging, and these vaccines are going to be safe. And I encourage everyone to get a vaccine once it is available. It will go to the elderly, and it'll go in New Jersey in particular. Governor Murphy has said the elderly and those who are challenged in nursing homes with comorbidities will get it first. Then the healthcare workers, doctors, nurses, etc., who are on the front lines. And then it'll go to police and fire, bus drivers, train conductors, people in essential services that need to be protected. So those are the vaccines. Now, there are several kinds of vaccines that you ought to know about, and they're not all the same. There's the genetic vaccines, which come from Moderna. You've heard a lot about Moderna. Moderna is a messenger RNA vaccine patterned after the RNA from the virus itself. And basically, it fools the immune system into thinking it's been infected when, in fact, it has not. And the immune response is robust, and there's no virus replication, but the immune system has now a memory in the adaptive immune response to combat the actual infection. Then you have the whole virus vaccines, which come from Chinese companies, which have been using these whole virus vaccines, that is injecting the weakened virus, much like we do with influenza, to prevent further infection. There's the viral vector vaccines that you've heard a lot about. That's the AstraZeneca Oxford trial. They were way ahead of the game. Why? Because coronavirus that causes the common cold, it's in the same family, they were already injecting chimpanzees last year in 2019 to try to make a vaccine to the common cold, and they were ahead of the game because they had a lot of preliminary data. So that's very exciting. Johnson & Johnson, Novartis, and Merck are also viral vector vaccines. The viral vector vaccine is essentially the virus particles being transmitted into your body with another virus that's harmless, an adenovirus. The adenovirus takes the viral vector, the parts of the COVID, and allows it to enter your cells, making the immune system again think that it's been infected with COVID-19. And lastly, there's the protein-based vaccines. Now, I wish I had my sample COVID. I have a little ball with spikes on it that I created out of a tennis ball. Anyhow, these little spikes are the proteins that the immune system recognizes as COVID-19. And these protein-based vaccines are the University of Pittsburgh, a company called Novavax, Sanofi is having this protein-based vaccine. So these vaccines are also going to be very useful. And as far as I can tell, they're in phase 3 as well. Phase 3 is the last phase, by the way. Let me explain the phases. I'm sure you're interested in that. That's the final efficacy trial where you put people on placebo and the vaccine and you see how they do. Phase 2 is an expanded phase 1, which is a safety trial. Phase 2 trial is the vaccine is given to hundreds of people, which are split into 2 groups, mostly the elderly and people of middle age. But more recently, phase 2 is being applied to children as well. It's possible that the vaccine, in some cases, perhaps the protein-based vaccine will have to be 2 injections. And I know the genetic vaccines may also wind up being 2 injections versus an injection like influenza where you get 1 shot in the fall. So I'm sorry that I probably exhausted all of you by talking about this most interesting condition. And I think I just gave you about 2 weeks worth of information in a period of, 40 minutes. And I want to thank you all for having me. And I just think that I enjoy talking about COVID-19. If it saves lives, God bless us all and hope for the best. Thank you very much, Dr. Patel, and to your committee, and to all of you out there who are watching.